Welcome to Straight Outta Health IT. Getting into health tech is rough, but here's an unfiltered dialogue of healthcare leaders and influencers covering a wide variety of issues affecting healthcare and the health tech industry. And now your host, Christopher Cunny.
Hello, everyone. This is Christopher Cunny, and welcome back to another episode of Straight Outta Health IT, where we explore the intersection of healthcare, technology, and policy that covers the future of our healthcare systems. I'm your host, as I mentioned, Christopher Cunny, and today we're going to delve into a topic that I think for some of us, it's still a little bit of a challenge to wrap our heads around, but for many of us who are now moving into those years where we're going to be tapping into these government-based healthcare plans, I think it's an interesting conversation to have. And so we're going to delve into the future of, and complexities associated with Medicaid, Medicare, and government health care programs in general. And who better to have on the program than one of the subject matter experts on this topic, a friend and colleague, Miss Ashley Gray, who's vice president at Sirona Strategies. And I'm so glad and excited to have her to help us navigate through the complexities of government healthcare programs. Ashley, thank you so much for taking time out your busy schedule to chat with us and clear up some of the questions and challenges we have about what's happening with our government healthcare programs.
Yeah, thank you so much for the opportunity to be here.
Glad to have you here. So before we get started, I'd like you to take a few minutes to share with our tribe a little bit more about your personal and professional journey. When I had an opportunity to meet you and learn more about you, I thought you have a fascinating story, and I think it's very appropriate for you to share that with our listeners, and they can get a sense of who you are and where you're coming from and what you're passionate about these days. So take it away.
Thanks so much. To sum it up in terms of my professional career and really how it's anchored in my passion, it's all been focused on the government program space, particularly for the Medicaid program. For me, I think it's a great mission and service to be able to work to advance healthcare and outcomes and access for a population that has historically, unfortunately, been marginalized in a lot of ways. And so now, and especially over the past 10 plus years, it's just been such a wonderful opportunity to be able to work in this space from both the private perspective and understanding a little bit about the federal government perspective. So in sum, my background's been grounded in Medicaid policy, particularly with Medicaid managed care. So I've done quite a few lives, so to speak, in the managed care space. I've spent some time working at Blue Cross Blue Shield Association, leading their federal and state Medicaid policy work. I've also done some tours of duty through the trade association space. I've worked with Medicaid Health Plans of America as well on Medicaid, state and federal policy. And outside of that, I've also really enjoyed getting a lens into how the Centers for Medicaid and CHIP Services in particular partner with states for the Medicaid program. And so I spent some time at MITRE as well, leading a pretty large contract supporting the data and systems group at CMCS, really supporting states in implementing Medicaid IT systems, certifying those systems, and seeing how states really carry out policy through the systems that they're implementing. So it's a wonderful ride.
That's great. And so, Tribe, as you can see, who better to have on this episode of Straight Outta Health IT than someone like Ashley, who's got years of experience and leadership in this area as well. So let's jump right into it. And let's start with Medicaid. The program has obviously gone under some significant changes over the years, but it continues to still face challenges, especially as healthcare costs continue to rise and populations are aging. There's this term called the silver tsunami that's happening. Every day, 10,000 people are turning 65 for the next 25 years, and will start to have a huge impact on the Medicaid program. What do you see as a future of Medicaid, particularly in terms of the sustainability of it and the ability to meet the needs of low income and vulnerable populations?
I think And I'm biased in this opinion, but I think Medicaid is just such a robust program. And truly, when we think of it as one of the core safety net programs for our country in providing a lot of that healthcare access, I think there's just so much opportunity in Medicaid, and it continues to grow in so many different ways.
Sure.
But to your point, sustainability is definitely a big factor. Home and community-based services tend to vastly outweigh a lot of the general budget when it comes to Medicaid. And as we think about the ways in which we want to approach long-term care for our aging population, especially for those who obviously fall within the eligibility criteria for Medicaid,
Sure.
we really need to, as a system, focus on how we can keep as many people as possible aging in place, right? And that means keeping them in their homes. It means keeping them in community-based settings where they're not, unfortunately, going to skilled nursing facilities unnecessarily, right? There's always that appropriate site of care for individuals. And so often, because of a lack of resources in the community or within the family unit, right? The household, there's so many individuals who are aging who go to nursing facilities, and that does mean cost. And it doesn't mean that they're always getting the care that they need, especially if they're a low risk kind of population that could easily reside at home with appropriate supports.
Exactly. And specialized or personalized care.
Yes, exactly. And I think as more states are looking towards those supportive services, right? Those personal care services that can keep individuals at home, it's a great opportunity, right? To move the needle on their outcomes and really make sure that they're getting the tailored care that they need. But that means also that we need a workforce that can match that. And direct care services and direct care workers, these are the people that are helping with your activities of daily living. They're the individuals that are helping families or individuals on their own with those like laundry activities, cleaning activities. They're helping to make sure their medications are also in line and filled. And there's so much around that requires a workforce that isn't there right now. And so I do think that's a big challenge for a lot of states when we think about building that workforce so that we do have individuals who can help individuals stay in the home. And I think the other aspect of that means that our community-based organization landscape across every state, across nationally, they're perfectly positioned to understand the needs of individuals and families in their communities. And so unlocking their ability to work with Medicaid, to work with payers and health systems in a way that allows them to bring their expertise to bear and to be that trusted voice of communities, but also integrated within a system that's very complicated is another opportunity where I think once we start to unlock some of those, we'll have a lot of sustainability that will come from it. But it does mean that healthcare plays its portion in the game, but it doesn't necessarily over-medicalize everything in the process.
No, absolutely. And just to help our tribe understand the true impact of this, the baby boomers who have dictated every major economic shift since 1948, those are the people who were born from 1946 to 1964. Roughly 70 plus million people were born during that time period. 70% of those folks now qualify for Medicaid, which has a huge impact now on, our healthcare system. To your point, the lack of resources available to support that aging population, the cost associated with that. And not only that, many of those individuals, and I would venture to guess a good majority of them, have one or more comorbidity issues that they're dealing with as well too, which continues to exacerbate our healthcare system and make it even more of a challenge to help those individuals age in place, because specialized care in some cases is needed for those individuals who are dealing with one or more chronic diseases. And the challenge we have and the opportunity we have is how do we get our arms around all of that? But many folks leaving the healthcare system, not replacing them fast enough. In many cases, those individuals who are aging are people who were in the healthcare system who now need to be patients and a part of the healthcare system. It's a real challenge that we have that we've got to figure out strategies to get our arms around that as well.
Yeah, absolutely. I think part of it too is seeing that nice interaction of public and private come to bear. And I think it's one of the promises of managed care in general, but particularly for Medicaid managed care, is that ability for care coordination and management of the whole person needs. of the members that are enrolled in these plans. And I think when we look at the landscape across the board, where we've got payers, we've got health systems engaging in value-based care and contracting and working with community-based organizations and providers to really provide that whole person care, that really means we can address those health-related social needs and keep folks in the community. There's a lot that's exciting about that. And I think there's a lot we're learning now too.
Absolutely. And a great segue into kind of my next question or topic. And you mentioned managed care and value-based payment models. How do you see these innovations specifically impacting dual eligibles, those who qualify for both Medicaid and Medicare? And what are some of those unique challenges these populations face as well?
Yeah, I think the duals population is an area where we've made a lot of effort to figure out how to bridge eligibility between both programs. But we've started from I guess our starting point, to frame it differently, is from this perspective of bifurcated care. And that bifurcated eligibility has really resulted in our approach now with providing benefits to this population. So we still look at it as this is what Medicaid covers. This is what Medicare covers. And so it's hard to bridge or braid together two programs that are conceptually very different in providing care for this population. So I think we've done a lot of great experiments, right? We've seen some fully integrated, dually eligible plans, those FIDE SNPs, working towards providing a more seamless experience and seamless coverage. And we've seen other MLTSS, managed long-term services and supports models out there as well. And I think we're learning a lot from these exercises, but I don't know that we've on the nose necessarily solved for this issue yet of having a fragmented system for individuals who are both aged and low income. And so I do think value-based payment models and those experiments that we tend to see through CMMI are very interesting to learn from. But the replication of these experiments, I think, is where we haven't unlocked that next step. So I do think it is an area where we're going to have to continue to innovate. We're going to have to continue to examine, but also be very willing to scale these experiments so we can learn from them more broadly and disseminate those lessons learned. Because I do think, and this is also true for the Section 1115 waivers that we have in Medicaid, we're very interested in running experiments and we're very interested in seeing the results of those, but we're not always great as a system in sharing those best practices and rapidly scaling to see what we can really do to move the needle. So this is
more really failing fast, learning from that, and then regrouping and finding better ways to address these issues as well.
Yes, absolutely. So I think there's a lot more that we're going to still have to work through to make sure that we're really meeting the needs well for this population. And I think the cost that comes with those needs that have and sometimes been unmet for decades and now are being addressed. And so there's a lot of opportunity to do justice for this group, I think. And I think that's, for me, where as a person who cares about health equity very deeply, the duals population is really no better indication of our progress in achieving health equity, truly.
Wonderful. Yeah. Yeah. And to your point, that lack of coordination between the two programs can lead to obviously fragmented care and higher costs and poor health outcomes, and managed care and value-based payment models can have the potential of helping to incentivize providers and to coordinate care and be more effective and focus on the quality of care versus quantity of care. That's always the challenge we have in this today's modern healthcare model. And it's really crucial that these models are designed to meet that dual eligibility concept where it occurs, especially for those underserved. And so coordination seems to be really that key theme. How do you see public health initiatives integrated with Medicaid and Medicare programs to better serve kind of this dual eligibility population and address the issues of the underserved?
Yeah. I think this is where, from a health IT perspective, there is just so much opportunity to bring data into the equation and to communicate data across the board. So interoperability, I think, is huge in this space. It's an area where we're chipping away at the lack of interoperability, particularly from the public health perspective. and the state to federal perspective, because there's a lot of different dynamics, right? You have your on the ground provider, payer, health system, patient interoperability, and that exchange of information so that care teams can not only identify what a patient needs, but communicate that across the board and refer them to the right resources and close gaps.
Exactly.
And that's one microcosm. But then we've got the relationship between the local and state, right? So making sure from a state Medicaid agency perspective that they're getting the information that's needed to be able to administer the program and to facilitate a better understanding of who they're providing access to, who they're providing care to, and then state to federal. The translation of the data that the states are then capturing and sending that from a national perspective can say, hey, these are some really interesting case studies that we can pull from multiple states on this particular area. And look, now we can share these lessons learned. We can help states troubleshoot the needs that they need to troubleshoot. So it all comes back to this collection and dissemination and translation of data. And I think that's one of the things that's been most exciting. When I professionally graduated from focusing on health policy and this pure public policy perspective, right? I looked at benefits and I looked at the patient experience and understanding how that worked and what that translated to access and costs and quality.
Right.
But then I finally graduated from that perspective and ended up working in Medicaid IT. And I learned so much about the lack of available information that's needed, the data, that the way it's being captured, how states are able to even access their own data. And so I do think that when we're looking towards how to better meet the whole person needs, whether that person's a Medicaid beneficiary or a dual or a Medicare enrollee, it's agnostic of the program. But when we're trying to really understand and crack the nut on addressing those whole person needs and really making sure that from a health-related social needs and social determinants of health perspective, we're really addressing those, we need the data. And that helps not only for the system to understand the patient, but for the patient to understand their own needs and to empower them. And as a result of that, that builds trust as a patient that I know the system is going to meet my needs, that this program is there for me and is there to support me as I go through my own health journey. And so that's an area where I am so excited to see all the advancements we're making in interoperability. And just recently, the HTI-2 rule was released by ONC, and that's trying to move the needle on public health interoperability. As we more holistically look at how we can marry and connect systems together, that's where we're going to be able eventually to do some really robust
realize the
for this population.
Yeah, absolutely. I was thinking when you were talking this whole concept of holistic integration, people, process, technology, right, between public health initiatives and Medicare, Medicaid programs is really essential, especially comes to your point in addressing the whole social determinants of health issues, the digital determinant of health issues, the political determinant of health issues, all these things that have a direct impact on public health programs play a crucial role in preventing disease and promoting healthy lifestyles and behaviors and dealing with things like food insecurity and transportation and all these other for housing and other factors that have a direct impact on someone's overall well-being. And the fact that you mentioned earlier that we don't have enough people to satisfy this growing population of individuals who are moving into these health systems, we've got to depend on things like technology to help close those gaps or at least mitigate some of it to some extent, being able to do more virtual care type programs and have technologies of doing things like passive monitoring of patients and patient-centered medical home solutions that allow the patients to age and where they are, programs that the federal government and private sector are going to have to double down on in order to get our arms around this. Otherwise, it's going to be, again, a health crisis that will exist in our country in a not too distant future. I'm curious from your perspective, you talked about policy changes or innovations that you believe are necessary. Could you maybe expound a little bit more on that on the Medicare, Medicaid programs, and especially as it relates to dual eligibility?
So I think I'm going to actually bring this back to data again. I think for the longest time, as we've tried to understand these populations, we've collected data in somewhat of an intentional way, but it's always been grounded from the perspective of what the health system needs to understand about the patient. And not necessarily a 360 view, right? Like it's not the patient's perspective and experience, it's the community-based organization's perspective and experience, it's everybody. And so I do think that when we think about policy changes, we've informed our policy solutions on incomplete data, right? We've thought about certain domains, but we haven't collected all the ones that might be important to understand and to learn from interventions that are really powerful.
Or even just looking at it from one lens as well, too. Like not looking at it from a broader, to your point, holistic lens.
Absolutely. So I think we've done our best as stewards of government health programs, public health, to really try to create these interventions and these policy solutions, but we didn't always have all the right data that we needed at the time. And so that impacts naturally the result of those and truly what we actually do learn from them. And so as I look at the push and the focus to gather more social drivers of health-related social needs data, that can help us in so many ways to really tailor interventions that make sense, to fully leverage AI and machine learning, right? The algorithms and the structures that we build are based on currently imperfect data. Not that you can ever achieve perfect data.
Right. But you can govern it as much as you can and enhance the efficacy of it and hopefully improve the accuracy of it over time as well.
Exactly. And so I think now that we're in a place where we're collecting more robust demographic data, where we're understanding the impact of data analysis that is grounded on these non-clinical drivers of health. And when we're looking appropriately about how demographics do play into understanding and concluding from the data sets that we have, I think we're in this bright new future where we can actually start to have more informed interventions that can yield better outcomes, that can then inform policy and policy changes that we might need to make. And so I don't necessarily want to be too prescriptive about what particular solution or intervention, but I do think as we are more from a healthcare landscape appreciating data, and I know I'm probably preaching to the choir for those of us that have been working in the interoperability, the EHR space for a long time, but as the rest of the reformed policy folks who have only been focusing on the benefit and the structure side are starting to appreciate the value of unlocking data and collecting the right data, I think we're getting to a better place where we're making good decisions based on better data, right? The data is informing the appropriate solutions and in a way that I think is cognizant of the fact that we are looking at whole people and we are looking at whole person needs. Yeah.
And democratizing that data as well, too, taking advantage of insights that are coming from EHRs and that shared through HIEs and through other data lakes of information from different groups, whether it's, again, public health or research or providers, payers. All of that information has aggregated in a way can help improve outcomes and give better insights and allow us to focus on better population disease management and more precision healthcare as well. And then dealing with those factors that we have in the past traditionally not invested in a lot, those social determinants that have a direct correlation on someone's overall outcome and ability to receive quality care.
Yeah. And I think too, it's not just the health data that is at the crux of this, right? I think we're now appreciating and considering how to integrate sources from housing, from workforce, from justice-involved populations. So
personal devices that people are wearing that are giving indications about their health as well, too. Those things are becoming much more, the data coming from those have a higher quality than they may have had in the past as well, too.
Exactly. So we've got this just novel, not only is the health tech itself really cool and interesting and more accurate and really personal, right? That's such an interesting personal level of data, but from a system of systems perspective, being able to have a linchpin. And I think this is why health information exchanges also can be very fascinating and the powerful tools to help public health and Medicaid and commercial, but all populations better understand the people that are enrolled in their programs.
Talk to me a little bit about the need to make sure we have a diverse workforce as well, too.
Yeah.
as we start to address these challenges and managing these diverse populations.
Absolutely. I think one of the things that is critical to understanding that the ability to move the needle on health outcomes
Right.
is that this is actually predicated on trust, ultimately. Trust between the patient and the provider, the payer, the health system,
Exactly.
state government, federal government.
Right.
In order to actually be able to drive change, we have to make sure that the individuals that we are serving have trust in the system to do what it's going to do for them. What we say that we want to achieve is actually what we do achieve. And so I think as a part of that, in order to build trust, you also have to have a system that not only works efficiently and all those good things,
Sure.
but is managed by people who look like those that you're serving, right?
Like the community.
Yes, who have lived experience, who are also aware of cultural competency and languages and on all those things, right? We can't foster trust if we don't have that whole perspective. And so I think as we look to whether that's a direct care workforce to help those aging in place, or whether that individuals who are working at state Medicaid agencies and directly interfacing with Medicaid beneficiaries, or you name it, it's provider practices, community health worker, like everybody. I think there's such a critical need to account for diversity and to intentionally do so to make sure that we're actually, as a system, we're not necessarily missing the opportunity to connect with a person.
Right.
And to truly understand their experience and be able to really guide them through and connect them to empower them in their own healthcare journey. So I can't speak enough. I think for me, my background, I come from a Caribbean household. My mom's Jamaican, my dad's Puerto Rican, and it always helped when I was with my family who's older, or even now with friends and family. It always helps to see somebody who looks like you, or at least understand where you're coming from in providing care. And so I do think it's just very critically important that we are intentional about diverse workforce and diverse approaches to engaging the patients and the individuals that we're serving.
No, absolutely. I think those are all critical factors that help us improve the delivery of care and help the patient population trust the healthcare delivery systems that we have as well, too. And before we wrap up, what are your thoughts on the kind of the broader implications of these things for public health, and how does the future of Medicaid and Medicare for dual eligibles tie into the overall health of the community at large?
Yeah.
Yeah.
So I think if we look at Medicare and Medicaid as individual programs, we've got a very large portion of our population covered.
Yes.
And so in a lot of ways, these two programs can really help inform those individuals who might not be covered by these programs and the care that they need and approaches that are successful. And so I think as we look for how public health and government programs connect and work together, and we think about addressing from a systematic perspective social determinants of health so that we can move the needle on those individual healthcare needs, I think we need to continue this focus of intentionality, of collecting data, the right data in the right way, of making sure our workforce is diverse and able to understand those social and health related needs, that we're engaging individuals in the communities, these community-based organizations, community health workers, promotoras, people like that who can really be that guide and that connection point between health and the individual. I think all of these are the right steps in the right direction. And I think for me, what I'm really interested in seeing is how we can adapt and be more agile in our learning in this space. So as we continue to appreciate and adapt and learn, making sure that we're doing so in a way that makes sure that policy is rapid in its response, right? You want policy to be very well thought out. You want it to be intentional, based on the right data. And that's important. But now we're moving with a speed that allows us to make informed decisions on policy solutions that we can actually implement quickly too. So I think all of these areas really mean that we're moving in a direction where we're taking a more cohesive and integrated approach to how we view health, how we view individuals.
And I think we're focusing more on health versus care. Now we're starting to think about how we focus more on the health side versus just the care side
Yes.
as well, too, because ultimately if we keep people healthy,
Yes.
it helps to drive costs out of the care side of the business as well, too.
Absolutely. Absolutely. So we're moving the needle in really great ways. And I'm just excited to witness it and also just be a
Part of it.
all of this. Yeah.
That's great. So final question, if you could wave a magic wand and change one thing in this very fragmented, dysfunctional healthcare system that aspires to help everyone. So I don't want to say that in a way that people aren't really committed to the mission of care, but the reality of it, we still have challenges. If you could wave a magic wand and fix one specific thing today, what would that be?
Oh, goodness.
I know it's a loaded question.
It is. If I was queen for a day and I could fix anything.
The Wizard of Healthcare Oz.
Yeah. This is going to be it's a grand gesture. It's not probably a little thing, but I would say if we could turn our view and approach of safety net programs on its head, right? We created all of these out of individual needs. Like we need a safety net program for health, for housing, for utilities, for all food. We created these wonderful programs that do so much for so many in their own silos. So if I could wave my magic wand, it would have been to perhaps jump in a time machine and say, hey, when we were creating these programs, let's look at aligning eligibility across these programs so that we can get people in at the same time across the board. Let's integrate our approach. Yeah. And then that way we could say as a safety net, which is the purpose of it is to make sure that those who need are able to receive the care that or the benefits that they're entitled to. If we could approach this from a perspective where everything started from a level playing field, so everyone's getting a full package or a full wrap of services, right? If I am housing insecure, I can get that as well as my healthcare and access to food. If I waved my magic wand, went in my time machine and was able to fix that, I think we would be
more integrated,
leaps and bounds ahead of where we are today and more integrated. So that would be my magnanimous change because it's not a small.
We're going to let you drop the mic right there on that final thought and that final wish, and from your eyes to the man upstairs ears. Thank you so much, Ashley, for sharing your insights today and talking about kind of the future of Medicare and Medicaid and the impact on dual eligibles and public health. It's a complex and ever evolving topic, and we just thank you for your commitment to it and helping to transform the industry and allowing us to have better lives as well, too. For our listeners who are interested in getting connected with you and learning more about what you do and how you might be able to support them, how would they reach you?
Definitely reach out on LinkedIn. I am on it and available. My email address is also associated with it. So I love any opportunity to connect and to chat further.
Wonderful. And we'll have all of her contact information, at least the ones that she shared, in the transcript notes as well, too. So thank you so much, Ashley Gray, Vice President at Sirona Strategies, for offering your insights on the future of Medicaid, Medicare, and government healthcare programs. And thank you, Tribe, for taking time out your busy schedule to check out another episode of Straight Outta Health IT. Don't forget to subscribe and to leave a review. And if you enjoyed today's discussion, please share it with your friends, colleagues, family, folks you don't like, anyone that can benefit from this very important topic. We do appreciate your continued support. Take care. Until next time, God bless.
Thank you so much for listening to Straight Outta Health IT. We hope you enjoyed today's guest. For more unfiltered dialogue of healthcare leaders and influencers, be sure to tune in next week. For the show notes, transcripts, and resources, please visit Apple Podcasts, Spotify, or your favorite streaming platform. We invite you to give us feedback by reaching out to Christopher Cunny on LinkedIn, just searching for Straight Outta Health IT, and you'll find us. We are constantly having live discussions about diverse topics in the industry.